Good morning, everybody. Thank you so much for inviting me for this program. Moving on to my topic for today, preseptal cellulitis. As ma'am already mentioned, orbital septum is the extension from the periosteum of the superior orbital rim in the upper lid to the levator attachment and to the capsulopalpebral fascia in the lower lid. So infection of the soft tissue of the eyelid and periorbital structures anterior to the orbital septum is preseptal cellulitis. So this preseptal cellulitis is more common in children than in adults. So its etiopathogenesis could be exogenous, extension from adjacent infections, or endogenous. Exogenous most commonly is trauma, insect bite, or any eyelid surgery. Extension from adjacent infections of the face. Facial veins are valveless, so spread of infections from contiguous sites could easily occur. Most common in children is sinusitis. Ethmoidal sinus being very close to the eye is most common reason. The rest being dacryocystitis, hardiolum, and impetigo when severe lead to preseptal cellulitis. Endogenous is hematological spread from the middle ear infections or upper respiratory tract infections. Rarely in immunocompromised patients, septicemia could also lead to preseptal cellulitis. The most common causative organisms, it's mostly bacterial. Mostly it is Staph aureus, strep pyogenes, or H. influenza. H. influenza being very rare now. Staph aureus and Staph epidermidis could occur, infections could occur following trauma. Methicillin-resistant Staph aureus is on the increase. Streptococcus pyogenes and Streptococcus pneumoniae in case of sinusitis. H. influenza in sinusitis in unvaccinated children. Other rare causes could be anaerobic bacteria from dental abscess and sinusitis. Virus being adeno and varicella. In immunocompromised, fungal infections can also lead to this, mucor and aspergillus. Signs and symptoms, if you see, is most commonly edema, erythema of the skin around the eye. Pain rarely present. Not very severe, it will be mild. Vision, extraocular movements, and the rest of the conditions will always be normal. So most of the times, the treatment is oral antibiotic, so it is started empirically. Investigations is not needed always. But when done, complete blood count could show leukocytosis. Culture is usually not needed, but if there is some discharge or pus from the lesion, it can be taken. CT orbit is usually indicated when you think the patient is progressing to some complication. Otherwise, it might not be needed. In case of trauma, to look for presence of foreign body, it can be taken. So CT orbit usually shows in soft tissue enhancement in the preseptal regions. The orbital region otherwise would look normal in case of preseptal cellulitis. When there is extension, so it means patient is going in for some complication. So complications, I think, would be covered in the next by the next speaker. Could be or extension, which is orbital cellulitis, subperiosteal abscess, orbital abscess, cavernous sinus thrombosis. This is a Chandler classification. The other rare complications are meningitis, brain abscess, septicemia, and necrotizing fasciitis. Necrotizing fasciitis in itself is a separate entity. It is also most commonly caused by trauma, but the organism has a different pathogenesis where there is angiothrombotic effect, collagenases act, so there is gaseous presence. So if you're going to take a CT, you would see air in the air pockets in the thing. It is very severe and could be life-threatening if it is necrotizing fasciitis, and it needs extensive treatment. So what do we look for? When you see a preseptal cellulitis, it is very easy to treat actually, has a very good prognosis. What should we look for is if the patient is progressing to orbital cellulitis. So proptosis, presence of proptosis, decrease in vision, restriction of extraocular movements, when the pupillary reaction is sluggish or patient is having an RAPD and color vision is defective. So you should definitely think in terms of orbital cellulitis, and preseptal has definitely progressed. So differential diagnosis could be conjunctivitis, contact dermatitis, herpes zoster, inflammatory orbital disease, or thyroid exophthalmos, angioedema, and dacryocystitis. If you see this condition, there is bilateral lid edema, but the color of the skin is normal, and there is facial puffiness. So this is angioneurotic edema. This obviously, this is hardiolum internum. This The skin, if you see, there is scaling of the skin and it is contact dermatitis. This I think you would make up. It is actually preseptal cellulitis due to dacryocystitis. Herpes zoster ophthalmicus also. Initial phases, it wouldn't appear like this. The crusting doesn't appear on the day 1 or 2. Patient just has pain. I have seen patients, because I'm working in a general hospital where we have all specialties. Derm people refer the patient to us with just lid edema. But if you see carefully, there'll be an erythema just on the forehead above the lesion. We being a little dark skinned people, that wouldn't be obviously seen. So it would take 4 to 5 days for the crusting to actually appear. If you treat the patient with just antibiotics, it wouldn't be effective. So you should start the patient on acyclovir. So we see a lot of patients like this. I recently had a patient who was given lubricants for herpes zoster ophthalmicus, seen on the first day of OPD at Arvind. Luckily, I saw the patient on 3rd and 4th day. So the crusting had slightly started. So it would appear very simple. It is very obvious, it looks, but initial phases, it would appear like periorbital cellulitis only. But only if you look at the skin carefully, you will notice this. So treatment, most commonly what we give is amoxiclav, 675 mg for adults, QID, 7 to 10 days, can be extended for 14 days. For a pediatric age group, 45 mg per kg per day. The other being broad spectrum cephalosporins. In case of methicillin-resistant Staph aureus, clindamycin would be effective. But the complication being pseudomembranous colitis, so you should watch for it. Trimethoprim and sulfamethoxazole can be given, but you should check if the patient has a sulfa allergy. Doxycycline can be given, should be avoided in children less than 8 years of age. The others being supportive management being warm compresses, NSAIDs. IV antibiotics can be started if you think the condition is progressing, and in severe cases, we usually give third generation cephalosporins, the others being ampicillin, TMP SFX, and vancomycin in case of methicillin resistant. So as I said, it is usually has a good prognosis, can be treated as an outpatient. Broad spectrum antibiotics oral antibiotics are the mainstream of treatment. Usually there is improvement in 24 to 48 hours, reduction in pain, redness and swelling. If you think it is progressing, you can always admit the patient to look for complications. Thank you.